Hello, friends. So, this is a talk on hypoadrenalism, which is a decrease in function of the adrenal gland. So, the adrenal glands, as mentioned in the hyperadrenalism section, are responsible for the production of various hormones. And these hormones include aldosterone, which is stimulated by angiotensin 2, cortisol, which is stimulated by ACTH, various androgens, which are stimulated by ACTH, and epinephrine, which is stimulated by the autonomic nervous system. So hypoadrenalism is can be various different things, but primarily we're going to talk about Addison's disease. And the reason for that is because we talk about the other diseases in other sections. So hypoadrenalism can be broken down into three different categories, and this isn't any kind of official categories. These are just my categories that I think are useful. And they are primary, and that means that there's a disease of the adrenal gland itself. And generally that's going to affect all adrenal hormones because the adrenal gland is what's affected. And those include Addison's disease, which we're going to spend our time talking about today. Waterhouse-Friderichsen syndrome, which is an emergent disease, and that's due to hemorrhage into the adrenal glands, and that's secondary to a meningococcal infection. There's also primary hypoadrenalism due to surgical removal. Generally, that's due to there being a neoplasia. Miliary TB can infiltrate the adrenal glands and render them non-functional. Hemochromatosis can infiltrate the glands, and then head injury, which actually, now that I think about it, that should probably be under secondary. So cross that out. Okay. Secondary hypoadrenalism is due to a decreased stimulation of the adrenal glands. So that's going to be due to decreased ACTH or decreased angiotensin 2, etc. So the two major hypoadrenal diseases are pituitary apoplexy and Sheehan syndrome. And we talk about these in a different section, in the pituitary diseases section, because these are indeed pituitary diseases. Both of these can present in emergent manners, but when you have disease that affects the pituitary, generally ACTH is the last hormone to be affected. So in most cases, this is going to be something that you expect, particularly with Sheehan syndrome. It's not going to be, it can be emergent, but generally it's not. With pituitary apoplexy, because it's sudden, you're getting hemorrhage into the pituitary, you do get a sudden, abrupt decrease in all of your pituitary hormones, and so this indeed can be emergent, and the emergent factor is indeed the hypoadrenalism, because adrenal hormones are responsible for maintaining blood pressure. Then there's viralizing hypoadrenalism, which we'll talk about in a different section, and that includes congenital adrenal hyperplasia. This is due to an enzyme deficiency, and it's congenital, as mentioned. That enzyme deficiency blocks the production of aldosterone, and the result of this is that the steroids are shunted into forming adrenal hormones, and so you get an increase in androgens, and so that causes viralization. We'll talk about this in a different section. Okay, so we are going to focus on Addison's disease in this section because it is the primary form of hypoadrenalism. Addison's disease can be caused by many different things, but approximately 80% of Addison's disease are generally autoimmune. And so this is idiopathic sometimes, but generally it's autoimmune. And it's a disease of the adrenals leading to destruction or loss of function. Less common causes of Addison's disease, as mentioned previously, include hemochromatosis and miliary tuberculosis. Particularly miliary tuberculosis, we don't see in the United States. Hemochromatosis is rare, so we don't see that so often. And particularly if the hemochromatosis is well controlled, it should not lead to Addison's disease. So most of the time when we see this, it's autoimmune disease. And as a matter of fact, it can occur as part of a polyglandular autoimmune syndrome. So it can occur in conjunction with Hashimoto's thyroiditis, for instance. Addison's disease itself is rare. It tends to present in children, and it can present also in people aged 30 to 50. But you should suspect it in anybody who shows signs of hypoadrenalism. Addisonian crisis is really just another name for acute adrenal insufficiency in a patient with Addison's disease. This is what we're trying to prevent when we treat Addison's disease. Addisonian crisis, acute adrenal insufficiency, can kill you. If you haven't seen my section on acute adrenal insufficiency, you should watch it, because treating acute adrenal insufficiency is absolutely of paramount importance in emergency medicine, in making sure that the patient doesn't die, because you can die very easily from acute adrenal insufficiency. So adrenal crisis, Addisonian crisis, acute adrenal insufficiency, they're all kind of used interchangeably. Addisonian crisis is just the term for acute adrenal insufficiency, adrenal crisis, in a patient with known Addison's disease. This is generally, well, actually it's always secondary to a known or unknown stressor. These are things like pain, inflammation, and sometimes Addisonian crisis can be the first manifestation of Addison's disease. Hopefully not, but it can be. As mentioned before, Addison's disease may be part of a polyglandular autoimmune syndrome. There's several different polyglandular autoimmune syndromes. You should just know that they exist, and know that Addison's disease, Hashimoto's thyroiditis, and so forth, if they occur together, that's not unusual, because they're all autoimmune, and autoimmune disorders tend to occur together. If you have one autoimmune disorder, you're predisposed to other autoimmune disorders. The main features of Addison's disease is hypocortisolism and hypoaldosteronism. And that is because, remember, that Addison's disease is an attack on the adrenals as a whole. And the adrenals make cortisol and they make aldosterone. So if your adrenals are attacked as a whole, you're going to have decreased production of cortisol and decreased production of aldosterone. So the symptoms of Addison's disease, provided that you're not presenting in a crisis, are going to be very insidious. These symptoms are relatively nonspecific, except for a very select few. Salt craving is something that we generally don't see in patients with other disorders. However, it's also not very common to see in most patients. Orthostatic hypotension is a sign of dehydration, which happens in patients with Addison's disease because they have difficulty retaining fluid in their kidneys. Progressive weakness can be a sign of Addison's disease due to the low sodium levels. Weight loss and increased skin pigmentation. Well, the weight loss happens because cortisol is a factor in the differentiation of adipose tissue, and increased skin pigmentation happens because patients with Addison's disease have increased level of ACTH because of the decreased negative feedback, and the hormone in the hypothalamus that stimulates the release of ACTH also stimulates the release of melanocyte stimulating hormone, which certainly can work, and that is responsible for differentiating melanocytes and pigmenting the skin. Nausea, vomiting, and amenorrhea are also signs of Addison's disease, but those are also very nonspecific. On physical exam, you're not going to see a whole lot unless the patient has skin pigmentation. So most patients will have a blood pressure that's mildly low or in the low normal range, but certainly a normal blood pressure does not rule out Addison's disease. Increased skin pigmentation is more specific for Addison's disease. You're going to see this on the oral mucosa and on the palmar creases most prominently. So definitely be looking on the lips, look in the oral mucosa, and take a look at the patient's hands. The palmar creases tend to be the first place that will have elevated skin pigmentation. You may see evidence of dehydration, sunken eyes, decreased skin turgor, and sparse pubic hair. and that's related to to a low level of adrenal androgens. On labs, this is going to be where you are going to get your big suspicion of Addison's disease because of the characteristic labs. So you're really going to be combining your symptoms and physical exam with your labs, but your labs are really going to confirm your suspicion based on symptoms and physical. So what does aldosterone do? Well, aldosterone reabsorbs sodium, and in exchange for that sodium, it kicks out potassium. So aldosterone causes hypernatremia and hypokalemia. Well, in Addison's disease, you have a deficiency in aldosterone, so you would expect the opposite. You have hyponatremia and hyperkalemia, and that's characteristic of an aldosterone deficiency. When you have the symptoms and physicals in conjunction with these labs, that is highly suspicious for Addison's disease, and at that point you should go forward with the best initial step in a patient that's suspected with Addison's disease, and the best initial step in a patient with suspected Addison's disease is a concentropin stimulation test. Concentropin is an ACTH analog, so this is just as good as injecting the patient up with ACTH. So this is not my work. I found this online, but this just kind of covers the major and some of the minor symptoms of Addison's disease or hypoadrenalism in general. So fatigue, lassitude, which is sort of decreased mental energy, malaise, which is decreased physical energy, weakness, anorexia, postural hypotension, syncope, GI symptoms, myalgias, and that's generally due to the electrolyte abnormalities, decreased libido, amenorrhea, weight loss, hyperpigmentation, hypotension, thinning of axillary hair and pubic hair due to the decreased level of androgens, and vitiligo, which is a separate entity, and it's an autoimmune disorder that tends to, well, I wouldn't say tends to, but it can coexist in patients with Addison's disease. It disproportionately coexists in patients with Addison's disease. And you'll tend to notice it because patients with Addison's disease are slightly hyperpigmented, and so the vitiligo in fairer skinned patients will be more pronounced. So this is a patient with Addison's disease and vitiligo. So you can see that you've got hyperpigmentation here and then spots of hypopigmentation. This could just as easily be a tan patient with just vitiligo, but this happens to be a patient with Addison's disease. And perhaps it's noted by the slender build, by the sparse pubic hair down here, but you really don't know that this patient has Addison's disease necessarily, but clearly they have vitiligo. Now, you would want to check this patient for Addison's disease if they have symptoms, and of course, we'll talk about how you do that test. This is the hyperpigmentation, and like I said, you should look at the palmar creases and the oral mucosa. So the lips include the oral mucosa, and as does the tongue, and so you can see hyperpigmentation on the tongue and hyperpigmentation on the lips, and then on the palmar creases. So these aren't dirty hands. This is increased pigmentation. So how do we test a patient for Addison's disease? So when you suspect adrenal insufficiency, first off, you've got to take any stabilizing measures necessary if the patient is in crisis. So if the patient's blood pressure is low, if they've got decreased mental status, if they're comatose or non-responsive, then in that case, if you're suspecting adrenal insufficiency, particularly if you have labs that show hyponatremia and hyperkalemia, you should immediately administer hydrocortisone, probably 100 to 300 milligrams intravenously, and then take your cortisol level. Take your cortisol level first, and then administer IV hydrocortisone. You want to take any stabilizing measures that are necessary first before you go off and do any diagnostic steps, and that's pretty obvious why. So the IV fluids, IV hydrocortisone, having your cortisol levels, and then if your cortisol levels are low, you can continue therapy. I address this sort of ad nauseum in the acute adrenal crisis section. So if the patient is stable and you're working them up for Addison's disease or any kind of adrenal insufficiency, Like I mentioned, the best diagnostic test is concentropin stimulation test. This is the initial diagnostic step. All we're doing here is we're injecting the patient with an ACTH analog, and the question is, do the adrenal glands respond? If the adrenal glands are diseased, they're not going to respond. Adrenal glands being diseased, that's primary adrenal insufficiency, which is Addison's disease. If the adrenal glands respond, then we know we have an ACTH deficiency, and the adrenal glands are indeed going to respond to the ACTH because there's nothing wrong with the adrenal glands themselves, we just have a lack of stimulation. So let's say that the adrenal glands respond, and generally the cutoff level is 18 micrograms per deciliter of cortisol, but you'll be told this on the USMLE. So if the adrenal glands respond, then we know that the adrenal glands are working and it's due to something in the pituitary or in the hypothalamus. Most commonly, this is due to Sheehan syndrome, which is a panhypopituitarism due to hemorrhage, and that's caused by, due to necrosis, and that's after childbirth. So that should be in the history. Generally, patients who have Sheehan syndrome will have difficulty with lactation and amenorrhea, prolonged amenorrhea after delivery. Pituitary apoplexy is generally an emergent condition, and these are patients who have pre-existing tumors of the anterior or posterior pituitary, and what happens is that tumor ruptures the arteries supplying it rupture and cause hemorrhage into the pituitary. And then a non-functioning pituitary adenoma can suppress ACTH secretion. Any of these diseases, because they are in the head, they're in the brain, you should consider a CT or MRI of the head based on your suspicion, and you're going to replace cortisol and mineralocorticoid because these things are deficient. Most of the time, though, you're only going to need to replace cortisol because you only have a lack of ACTH. Remember that aldosterone, mineralocorticoid, is stimulated by angiotensin II. And that's part of the renin-angiotensin-aldosterone system, and that's not dependent on ACTH. So you may need to replace mineralocorticoid in the event of extreme hyponatremia and hyperkalemia, but it's not always necessary. But definitely you have to replace the cortisol. This can be done with oral prednisone, but in emergent cases it should be done with IV hydrocortisone. Okay, so what happens if the concentropin stimulation test comes back and the cortisol level remains low? There's no response. Then that indicates that there's primary adrenal insufficiency because the adrenal glands are the problem. You're getting ACTH, you're getting the hormone necessary to stimulate the adrenal glands, but the adrenal glands, because they're diseased, are not responding. This is Addison's disease, and most of the time Addison's disease is due to an autoimmune disease. However, you may get CT imaging. It can be useful, particularly if the patient has a history of TB, but it's certainly not required. Most of the time, the vast majority of the cases of Addison's disease in the United States are due to autoimmune disease. So patients with Addison's disease, you're going to need to replace both cortisol, the glucocorticoid, and aldosterone, which is the mineralocorticoid. Why do you need to replace both in primary but only one in secondary? Well, in secondary adrenal insufficiency, remember that we have ACTH stimulation, we don't have ACTH stimulation, and so we're not going to get cortisol. Cortisol is reliant on ACTH stimulation. But mineralocorticoids like aldosterone are only reliant on angiotensin II, and angiotensin II we have. And so it's not the adrenals that are diseased, so angiotensin II is going to continue to go about its business. With primary adrenal insufficiency, the adrenals as a whole are diseased. So not only are we going to not be able to secrete glucocorticoids, but because the adrenals as a whole are diseased, we're not going to be able to secrete mineralocorticoids as well in response to angiotensin II. So we need to replace both glucocorticoids and mineralocorticoids. So we can replace the glucocorticoids or the cortisol with prednisone or with hydrocortisone. Hydrocortisone would be IV. Generally, that's done in an emergency. You can also use dexamethasone. And then the mineralocorticoid or aldosterone can be replaced with fludrocortisone, and that's PO. And then, of course, patient education is going to be very important in any disease, but particularly in Addison's disease because the treatment is primarily preventative. We're going to want to prevent the patient from going into crisis. So, as mentioned, the management for Addison's disease is preventative. And it's preventative with medical therapy. So the goal is to keep the patient out of adrenal crisis. The drugs that we give the patient are going to treat the Addison's disease. But what we always have in the back of our mind, and what should always be in the back of the patient's mind, is the potential for Addisonian crisis. And so the patient should always be aware of that being a possibility. We need to replace both glucocorticoid, I would say most importantly glucocorticoid, because it has such a huge role in blood pressure and other functions. And we need to replace mineralocorticoid. Primary, remember, glucocorticoid and mineralocorticoid replacement. Secondary, just glucocorticoid replacement is necessary. So to replace glucocorticoids, we generally use prednisone on the outpatient basis because that's PO. To replace mineralocorticoids, we use fludrocortisone. The patient should wear a medical alert bracelet indicating that they have Addison's disease and that they take hydrocortisone in case of medical events. Why do you say take hydrocortisone in case of medical events? Because if the patient needs to have the medical alert bracelet read, it means that they're probably not aware and not able to take PO drugs. And so you're going to want them anyway. If you have an Addisonian crisis, you want to get the drugs into the patient right away. So you want the emergency personnel to know, give the patient hydrocortisone IV, get this patient out of crisis. You don't want to give the patient oral prednisone. That takes time to work. So hydrocortisone IV, that they take hydrocortisone in the case of medical events. Most paramedics and emergency personnel are aware that with Addison's disease they need to give IV hydrocortisone, but there's always the slow one out there, so it doesn't hurt to remind them. Patients should also be advised to double or triple their dosage of prednisone if they become ill, and this includes even things like the common cold. And you're not going to cause problems by doubling or tripling your dose for a day or 2 or 3 of prednisone. That's not going to make you sick. But you can become very ill if you don't have enough steroid, and you do become ill because you can go into crisis. So if they become ill, it's best to err on the side of caution and double or triple the dose of prednisone. That's very easy. Just take double or triple what you would normally take. They don't need to double or triple their dose of fludrocortisone. So you just need to double the glucocorticoids. They should also do this if they're under stressful or painful situations, so like a tooth extraction, for instance, or they're going through a very stressful time in their life, like a loss of a family member. In general, err on the side of caution, because Addisonian crisis can be deadly. Taking an extra prednisone pill is not going to kill you at all. And then, of course, if they need to double or triple their dosage, they should seek immediate medical attention to have their cortisol levels drawn, because failure to do so can precipitate adrenal crisis. It's best to have a medical professional, a physician, to tell you, yes, you should continue to take X amount of prednisone, or no, you're fine, you can go back to your daily dose. Remember that failure to comply with this can precipitate adrenal crisis, and while you shouldn't scare your patient, certainly it's very, very much of the utmost importance to educate them of this, because this is possibly deadly. So these are some medical alert bracelets. Now this, I think, would be fine. It's better than nothing, but just saying Addison's disease isn't really enough for most EMTs and paramedics, because I hate to say it, but a lot of them don't know what that is. and it would be really, really good if it's on hand, if a paramedic can administer IV hydrocortisone emergently if the patient is in a severe state. So if they don't know that, then just having Addison's disease is not enough. This is what I would want if I had Addison's disease. And this is generally what's recommended, is to first state requires hydrocortisone and then put in parentheses Addison's disease. That should help the paramedic connect the two. Oh yes, I learned in paramedic school that Addison's disease, if they're sick, they need hydrocortisone. And then on the back, of course, have you should always, in any medical alert bracelet, have your name and street address on it, and in case of an emergency, this is who to call, a specific loved one, and that person will generally be educated of the disease, and they'll be able to help as well. A lot of times the paramedics will call, there'll be another person, even somebody who's not a paramedic, call that number, and they can tell that person what is normally done if they go into an Addisonian crisis, God forbid. And it was rumored that John F. Kennedy had Addison's disease, but he obviously did not die from that. And that's all I got for you.